Shri Mahavishnave Namaha. May Lord Dhanvantari bless us all with good health and success. Am I audible?
Yes, loud and clear.
Okay, thank you, sir. On behalf of NIMA-National Central, I would like to welcome all the dignitaries and delegates for today's knowledge enriching session, that is Pulse of Abdominal Hysterectomy. First of all, I would like to welcome Dr. Vinayak Tempurnikar, sir, that is President of NIMA Central, U.S. Pandey, sir, Secretary of NIMA Central, Ashutosh Kulkarni, sir, Treasurer of NIMA Central. Then I would like to welcome Dr. Kamini Dhiman ma'am, President of OBGY Central, Dr. Priyanka Nakadi ma'am, Secretary of NIMA OBGY Central, Dr. Vishnu Bhavne sir, Treasurer NIMA OBGY Central. I would also like to welcome Dr. Suhas Herlikar sir, President of NIMA OBGY Maharashtra, Dr. Manoj Gaikwad sir, Secretary of OBGY Maharashtra, Dr. 𝘼𝙬𝙃𝙔𝙎 sir, Treasurer of NIMA OBGY Maharashtra. So before we go ahead, I would like to give some few instructions to all that are common for all participants. Please keep yourself muted during session. If your mic is found unmuted or disturbing with speaker voice, you will be either kept in waiting room or removed from session to maintain decorum of the program. If you have any question, you may put your question in chat box or raise your hand. Now, without delay, I would like to brief everyone here the NIMA OBGY agenda. NIMA OBGY, that is National Integrated Medical Association, Obstetrics and Gynecology, Society of India. The aims impart education in supporting, protecting the characteristics, status, and interest of the integrated medical profession in general and practitioner of Strirog and Prasuti Tantra, that is integrated obstetrics and gynecology in India. Our objective is to spread knowledge and to foster education in integrated obstetrics and gynecology, including human reproduction, family welfare study, research in all the field, contraception control, and other allied problems. NIMA OBGY is committed to promote services for betterment of health of the community, maternal and child health, prevention of allied and diseases, their treatment with integrated approach of Indian medical medicine with modern science. So with this, let us continue our fifth webinar, that is Pulse of Abdominal Hysterectomy. So dear all, as you know, today's topic, that is Pulse of Abdominal Hysterectomy. Although hysterectomy is increasing nowadays, commonly it is performed by many clinicians. But to performing this need to be adequately trained and updated. So we are honored to have such great and knowledgeable our guest speaker, that is Sujit Shinde sir. I would like, it's my pleasure to introduce you all, that is Sujit Shinde sir. Sir has completed their graduation, that is BAMS from 𝘼𝙬𝙈 𝙃𝙔𝙎, Pune. Sir has done his post-graduation, that is MS in Prasuti Tantra and Strirog from Bharati Vidyapit Ayurved College, Pune. Sir is presently director of Matruchhaya Nursing Home. Sir is honorable consultant at Bharati Ayurved Hospital, Pune, as well as sir is consultant at various multispecialty, Pune. Sir is joint secretary of NIMA OBGY Maharashtra. We can briefly call him, that is surgical icon of now era. So I would like to invite sir to do today's section, and over to you, sir.
Hello.
Sujit.
Hello.
Yes, sir, you can continue your lecture. Honor.
Hello. Good evening, respected teachers and colleagues and friends. Thanks, Shweta, for nice introduction.
Good evening, sir.
Good evening. As all of you know, I am not a lecturer, so I don't have any, too much teaching experience. But don't worry, I have very good practical experience, which I am going to share with all of you. here we discuss the basic theoretical part of the hysterectomy, and then we move towards the practical approach of hysterectomy. We are talking about abdomen hysterectomy. Next slide. Hello. Hello, Shweta. Hello.
Hello, sir.
Yes, sir.
I am audible?
Yes, sir. Yes, sir. Yes, sir. Clearly audible.
Are you able to see screen?
Yeah.
Yes, sir. Yes, sir.
Okay. Now we start. So we will first discuss the basic theoretical part of the hysterectomy. As all of you know, the hysterectomy, how the words starts, hyster and ectomy. You know, the hyster means the uterus and ectomy is the surgical removal. So hysterectomy is defined as surgical removal of the uterus. Now, what are the roots of the hysterectomy? Abdominal hysterectomy is most commonly performed surgery. Then vaginal hysterectomy, laparoscopic hysterectomy, cesarean hysterectomy. And nowadays, people are doing robotic hysterectomy. So these are the most commonly, these are the 5 methods to do the hysterectomy. Initially, my topic was abdominal and vaginal hysterectomy, as discussed with the Priyanka ma'am and all others, Archana ma'am. But as per my experience, abdominal hysterectomy is most commonly done hysterectomy, and at least you know the at least when you do the 50 cases of abdominal hysterectomy, then any surgeon can have a good experience about the tissue, about the anatomy. Just a minute. Screen video this just a minute.
Okay, no problem.
So according to me, or according to the standard dictum, one should know how to perform abdominal hysterectomy. At least you have to do 50 hysterectomy abdominally. Then any surgeon can get a good idea about the pelvic anatomy, pelvic orientation, tissue orientations. And then after doing 50 hysterectomy, or after having experience of 50 hysterectomy of abdominal, then you can start a vaginal hysterectomy. As vaginal hysterectomy is slightly difficult and blind procedure, one should know how to handle the tissue. And after doing a 50 vaginal hysterectomy, one should attempt for the laparoscopic hysterectomy. So these are the standard dictums. So I request Priyanka ma'am, we will start with the abdominal hysterectomy. So
yeah, we will take a vaginal hysterectomy section later on.
Yeah, definitely. First we cover the abdominal hysterectomy. One should know the abdominal hysterectomy properly. Then we will move to the vaginal hysterectomy. Then we'll do laparoscopic hysterectomy.
Yeah, definitely.
Okay. So what are the type of hysterectomy? These are the simple type of hysterectomy: type 1, type 2, the simple hysterectomy, modified radical hysterectomy. All these are theoretical part. Everyone knows a radical hysterectomy, extended radical hysterectomy, partial extension of the pelvis. But depending upon the indications of surgery, we can do which type of hysterectomy you are going to perform. Most of the DUB cases, abnormal uterine bleeding cases, fibroids, simple hysterectomy is mandated. Simple hysterectomy will serve the purpose. If there is a malignancy, depending upon the malignancy, we perform the radical, extended radical, excentrations. All the procedures are depending upon the indications of the hysterectomy. And what are the indications of the hysterectomy? Most commonly performed hysterectomies for the DUB nowadays we call abnormal uterine bleeding, uterine fibroid, tumors, endometriosis. We perform the in CA cases we do the pan radical hysterectomies, and difficult TO masses, endometriosis, young patients, we do the subtotal hysterectomies. So these are the few indications of the hysterectomies. What are the complications? The intraoperative complications are hemorrhage, visceral injury, and anesthetic complications. And postoperative, immediate complications and late complications. In these complications, mainly hemorrhage and visceral injury are most common. Anesthetic will handle his own complications, but hemorrhage from the clamp, hemorrhage from the slippage of the ligature, and visceral injury mainly happens to the intestines and bladder, ureter, pelvic vessels. So step by step, we will discuss how to handle, how to prevent these injuries. And if these injuries happen, we will discuss how we can prevent these injuries. What are the immediate complications? Depending upon the complications, we will find these symptoms: hypovolemia, urine retention, cystitis, anuria. In late complications, we find the pyrexia, incontinence, scar adhesions, herniations in the same patient. So now we'll move towards the surgical demonstration. These are when we start the hysterectomy, we can discuss the step-by-step, stepwise hysterectomy. The first step is the anesthesia. After giving anesthesia, suitable anesthesia, it may be GA, it may be local anesthesia, that is subarachnoid block. The simple every hysterectomy generally position is supine position. Third step is painting and draping. I generally used to paint with savolon, betadine, and spirit. It will prevent the many infections or many wound adhesions. Draping is with the sterile drape. Now we'll start with the fourth and most important step, that is the abdominal opening or laparotomy. So we will start with the incision. The skin incision may be transverse or midline, vertical, and it is determined by the variety of factors, such as a presence of prior surgical scar, need of exploration of upper abdomen, size and mobility of the uterus, and desired cosmetic results. If prior incision exists, most surgeons prefer to use this incision. If the prior scar is cosmetically unacceptable, it may be excised at the beginning of the surgery or at the end of the procedure. The first step to identify is the site of the incision. How will you find the site? By putting 2 fingers above the pubic symphysis. After marking the incision with the scalp blade, we take the skin incision. Now, here, just we are marking the incision with the use of finger above the pubic symphysis. Once you mark the incision, I generally always mark the incision, or I always recommend to start procedure with the marking of the incision. So here will we start the skin incision with the sharp blade. After taking the incision, skin incision, generally I use monopolar cautery to prevent small scapulary bleed and ooze. So you get a very clean and clear surgical field. Once you open the fat layer, as we know, there is a superficial fatty layer and deep fatty layer. Superficial fatty layer is we can call it as fascia camper, and deep membranous fatty layer we can call it as scarpa. After opening the superficial and deep fatty layer, we can find a white structure, white and tough structure, which is a rectus sheath. White thick layer, that is a rectus sheath. As all of you know, a rectus sheath is nothing but the tendon of all the three muscles: internal oblique, external oblique, and transverse abdominis. As all of you know, is the rectus sheath is a very tough structure and it has a strength. We are not close. So it is very important to handle rectus sheath properly and close it properly. So otherwise it will give dehiscence, and in future it will end up into the incisional hernia. After that step, most important step is mobilization of the rectus sheath from the rectus muscle. So here is the mobilization of the rectus sheath from the rectus muscle. So you can see triangular muscle at the base, which is 𝘼𝙈𝙈 muscle, which is inserted above the pubic symphysis. By using Ellis forceps, hold the lower end of the sheath, pull it upward, and ask your assistant to give downward pressure. So counter traction and traction is very important in any surgical process. Here, I am separating the 𝘼𝙈𝙈 muscle from the rectus muscle. This step is not performed in every case, but for demonstration, I am separating. And when in difficult surgery, fibroid, you need a bigger incision. In these cases, we move the 𝘼𝙈𝙈 muscle till the pubic symphysis, and we can cut the white structure, that is rectus sheath aponeurosis. At the base of this white structure is rectus aponeurosis. If we cut that rectus aponeurosis, that is called Cherny's incision. So Cherny's incision is taken when there is a difficult hysterectomy, you are suspecting TO mass, you are suspecting, you want to take a small incision at the skin, but need a great space to operate.
Good point.
After that, after downward mobilization, we will mobilize a rectus sheath from the rectus muscle upward. If you say, actually, this is a private patient, so we cannot take a big incision. So I have taken a little small incision. But if you mobilize the rectus sheath from the rectus muscle properly, you will get good exposure. So these are the two important steps: mobilization of the rectus sheath from the rectus muscle. These are now what we are seeing right now. It is a stepwise opening of the abdomen. Just we open the skin, then fat, superficial fat, deep fat, rectus sheath, mobilization of the rectus muscle upward and downward. But few surgeons prefer to do single bed incision. Just for demonstration purpose, I have opened another patient in that way. Here all the steps are avoided, and just see abdomen opened in hardly 10 to 15 seconds. So this is another way of open the abdomen. But as per my experience, if you are dealing with a pathological uterus, if you are dealing with fibroids or any bigger pathology, try to open abdomen stepwise. If you know the anatomy properly, then you must open the abdomen layer wise, layer to layer, which will give a good exposure. As hysterectomy is generally not an emergency procedure, so try to avoid direct opening of the abdomen. So, as we see in the first slide, the complications of the hysterectomy. Hemorrhage, and second thing is injury to the viscera. So normally what happens when we are operating in the pelvis, there are two cavities, abdominal cavity and pelvic cavity. I generally use two mobs in the cul-de-sac and push it upward at the pelvic brim. I pack the intestines thoroughly. With the use of Dever's retractor, I maintain that packing throughout the surgery. In this slide, you can see there is only empty pelvis. So here is pelvis is totally divided, abdominal part and pelvic part. So chances of intestinal injury in such packing, almost we eliminate the intestinal injury. So basic step, you have to pack the intestine upward at the pelvic brim. Now we'll enter into the abdominal cavity. Now we can take the uterus out of the incision. Examine the uterus properly, examine the adnexa, examine the intestine, if possible, appendix. If some patients are complaining of pain, continued pain, USG report shows adenomyosis, tumors, or something hydrosalpinx of right side. In few cases, I have found there is a pathology in appendix also. So when you are doing hysterectomy for pain factor, always examine for appendix. Once the examination is done, we know the pathology. And after the knowing pathology, we can start the actual procedure. Hold the uterus by clamping the 2 clamps on both the cornu. So here is the. When we try to apply the clamp, I have retracted bladder with the one Devers retractor, posteriorly another Devers retractor. In this clamp 1, I want to preserve the ovary. So my clamp include tube, round ligament, and ovarian ligament. So this is the clamp 1. If you want to remove the ovary, we can, our clamp will apply on the lateral part. Here I want to remove the ovary. So my clamp will be include infundibulopelvic ligament and round ligament. This is clamp first in case if you want to remove the ovary. When we apply clamp to the infundibulopelvic ligament, you must know the anatomy of that side, because we know at infundibulopelvic ligament is the peritoneal fold moves from infundibulum of the tube to the lateral pelvic wall. So you must know the anatomy of the lateral pelvic wall, because here are the chances of injury to the ureter. At the base of the infundibulopelvic ligament, common iliac artery bifurcate into external iliac artery and internal iliac artery, and at the junction of the or at the bifurcation of this common and external and internal iliac artery, ureter moves downwards at the base of the infundibulopelvic ligament. So before applying clamp on the infundibulopelvic ligament, one must access to the ureter. You must be close to the ovary or close to the infundibulopelvic ligament. Don't go for lateral side. In case if you want to apply clamp laterally, or there is a pathology at tubo-ovarian mass which is extended on the lateral pelvic wall or big fibroid, in that case you must know how to dissect ureter or how to handle ureter. In that case, if you open the round peritoneum between the round ligament and infundibulopelvic ligament, you can extend that peritoneum 3 to 4 centimeter along the infundibulopelvic ligament posteriorly. And below that, you can easily see, after dissecting a fibropathy tissue, external iliac artery. And medial to the external iliac artery, you find a peristaltic ureter. You can external iliac artery, internal iliac artery, you can judge by putting a finger on them. You can feel a pulse. But on ureter, you see a transverse vessels clearly and peristaltic movement, which is differentiated between the ureter and the vessels. So you must know this anatomy properly. Then you can never injure to the ureter when applying infundibulopelvic clamp. If you are removing ovary, you must know the position of the ureter, position of the external and internal iliac artery properly. But if you want to keep the ovary, you are very close to the uterus. So in that case, you are not going to hamper ureter. So after the first clamp, you are putting ovary or you are removing ovary, the most important step is opening of the uterine artery or skeletonization of the uterine artery. So if you want to skeletonize uterine artery properly, you can see the proper uterine artery, there are less chances to injury to the bladder and ureter. So here we can see how we skeletonize the uterine artery. As we know the anatomy of the uterine artery. Uterine artery is the branch of the anterior division of the internal iliac artery. It goes downwards and medially at the level of the cervix and moves upward between the fold of peritoneum, that is called broad ligament. Broad ligament is nothing but the fold of peritoneum. Once we dissect the peritoneum properly, you will skeletonize the artery. प्ले करते हैं तो उस वीडियो पर प्ले करते हैं कैसा प्ले करते हैं. See here, anterior fold of peritoneum is separated. Now I am separating anterior fold of peritoneum. With the use of cautery, I am dissecting the 𝑃𝑜-cervical. White structure is 𝑃𝑜-cervical ligament. We are dissecting the 𝑃𝑜-cervical ligament. Now here I am dissecting posterior fold of peritoneum. I am lifting with the tooth forceps, and this is the uterine artery. So when you skeletonize the uterine artery and when push the bladder down, chances of ureteric injury is very, very less. Theoretically, we can say now here is the anatomy. Okay. We can know that uterine artery. We know the course of the uterine artery. Now we must know, before applying the clamp on the uterine vessel, you must know the anatomy of the ureter. As you know, ureter comes in the pelvis at the pelvic brim at the bifurcation of the external and internal iliac artery. It moves downwards, forwards, and medially. It passes the uterine artery from below. So water under the bridge, or just to remember, water under the bridge, and it is 2.5 centimeter from the internal os. But when we put clamp on the cornu, push the uterus upward, after dissecting the bladder and push bladder downwards, this anatomical 2.5 centimeter is the normal position of the ureter from the internal os in normal anatomical position. But when we operate on the uterus, we pull the uterus upward, push the bladder downwards. So it makes 4 to 5 centimeter distance from the internal os to the ureter. So chances of injury to the ureter in normal hysterectomy is slightly very less. Sorry. Now, what is the when we push the bladder? Now, many gynecologists from every faculty worried about the bladder flap dissection or bladder dissection. Be careful if there is a history of cesarean section. I generally prefer sharp dissection because sharp dissection is recommended at the use of blunt dissection with the sponge sticky may lead to a cystotomy or bladder injury or bladder laceration. If we do a sharp dissection, if even the bladder is open, you easily see the bladder injury and you can close it properly. Incision to the bladder caused by the sharp dissection is more easily repaired than the tear from the blunt dissection. When we give pressure on the bladder just to separate it, it will injure at any place. So it is very difficult to find leak from the bladder. So always use sharp dissection, cautery or scissor to dissect the bladder. Generally, bladder adhesion is found in previous section cases. But all of you know, when we do the cesarean section, generally bladder adherent is at the anterior to cervix. Laterally bladder is free. So generally what I prefer when dissecting the bladder, I don't try to push bladder downward or don't dissect the bladder at the surgical site of the cesarean scar. If you lift the bladder with the Babcock forceps and start dissection from laterally. Because laterally we get a virgin plane. Bladder is adherent at the cesarean scar only. Below that bladder is free. If you dissect the bladder from the lateral side, left side or right side, you will dissect bladder from the cervix very easily. And after holding that, if you get a plane, you start dissection from there, and always start give pressure on the cervix. Don't go the bladder side. And always remember, if you are dissecting bladder, if you find fat, so always remember, fat belongs to bladder. When you are dissecting bladder and you see the fat, it means you are entering into the bladder. Anatomy gives a clear indication that you are entering into the bladder by seeing fat. If you are seeing fat, stop there. Goes close to the cervix, close to the cervix. If cervical tissue remains, it doesn't hamper your surgery. And when you're doing a posterior dissection, uterosacral dissection, peritoneal dissection, or any mass dissection, if you find fat in that plane, it means you are going towards the rectum. So keep in mind, fat belongs to bladder in anterior side and fat belongs to rectum in posterior side. If you keep that fat plane in mind, you will never enter into the rectum. At least you get a pointer. You have to stop the procedure, or you stop the going in that plane. You go to the close to the cervix. So after that, third clamp is uterine artery ligation. So here I apply the cockroach clamp perpendicular to the uterine artery, close to the cervix at the level of the internal os. So here is the clamp and cut of the uterine vessels at the level of the internal os under vision. And this is the ligation of the uterine vessel. When you apply the cockroach clamp, make it clamp free from the uterus. And generally, I don't transfix that uterine vessel clamp, because when we transfix the uterine, there are chances to injury to the uterine vein or uterine artery there. And always keep finger on the knot. When you tie the clamp, any clamp in the pelvis, always keep your index finger on the clamp or on the knot, so the knot will secure, will not lose. Then you have very good control on the tissue of the uterus. Otherwise, slippage of the uterus or accidental torn of the uterine artery is very common. So your finger give control on the ligament, on the tissue, on your knot. So always keep finger on the knot. So this is the anatomy of the uterus, bladder, uterine artery, and how the uterine artery crosses the ureter crosses the uterine artery below. If you dissect all this structure, if you know this anatomy properly, and if you are able to anticipate this anatomy on table surgical, there are very less chances to injure ureter or bladder at the time of surgery. So avoiding urethral injury, open the retroperitoneum. This is this procedure we can do in case of difficult hysterectomy, in case of large fibroids, tumors, where you are getting very minimal space to apply the clamp. So in such situation, you are open the retroperitoneum and visualize the ureter on the posterior leaf of the broad ligament peritoneum to prevent urethral injury. Visualization of ureter peristalsis confirms its identity. Elevating the infundibulopelvic ligament prior to division creates a space between the ureter and ovarian vessel and ensures that the ureter is not included in the clamp. Practically, if you are open the round ligament, as soon as when we open the round ligament, we enter into the broad ligament. Just hold the anterior lip of broad ligament with tooth forceps and start cauterization towards the UV pouch, uterovesical pouch, and start dissecting posterior peritoneum. If we dissect the fibrofatty tissue under the broad ligament, you will find the external iliac artery on the lateral side, internal iliac artery on the middle side, and ureter in between external and internal iliac artery. Keep that ureter under vision before applying clamp to the infundibulopelvic ligament in case of difficult hysterectomy. If you dissect it further, you will find a uterine artery. Remember, only one artery moves lateral to medial is uterine artery. So it is very simple to find uterine artery at its origin because it only moves from lateral side to medial side above the uterus, above the ureter. So it will help you to dissect further and to ligate the uterine artery. After the uterine artery ligation, the third clamp is uterosacral and McIntosh clamp. If you dealing with pathological uterus, elongated cervix, then you may need third and fourth clamp to the ligate the uterosacral and McIntosh clamp. When we apply any clamp after the uterine artery, always remember, always medial to the first one. When you can apply 2 clamp, 3 clamp, 4 clamp, but all clamp must be medial to the uterine artery. Then and then only you will never injure ureter. So always remember, always medial to the first one. So here is you are ligating in one clamp, uterosacral McIntosh ligament. Some people are cut with the scissor, some use blades, some use cautery. You will decide about your comfort. You can ligate this uterosacral McIntosh with the use of 𝘋𝙀𝙈𝙄 number 10. 101 number. Here you can easily see with the use of divers, I am holding the whole intestine above the pelvic brim. So here chances of needle injury, chances of scissor injury to the intestines are almost nullified. Once you ligate the uterosacral McIntosh ligament, the last step is vault opening. So how will you open the vault? If you dissect it properly, uterus moves upward. It will come near the skin incision. By applying clamp, you can judge the vagina from the cervix. If you are confident enough you are opening the vault, you can remove the clamp. That tissue will not going to bleed. As this patient is in subserosal fibroid, she is bleeding. So this is collected blood. Now what we'll do, we do the circumcision of the cervix. We cut close to the cervix, so it will never injure to bladder or anything tissue. You can judge the cervix and vaginal junction by using fingers. If you put posterior 2 fingers, anterior 2 fingers above the uterus and below posteriorly, if your fingers are closing anterior and posterior part, that it means you are entering into the vault. After experience, you can feel it with the instrument also. Like I apply the clamp. So this is once you open the vault, you can put 3, 2 or 4 LEs at the corner, hold the vagina properly, and then close it with 𝘋𝙀𝙈𝙄 number 1. You see it, I take the angle properly. Okay. I am closing it with interrupted suturing, continuous interlocking. So there are 2-3 ways of closing the vaginal cuff courses. You can close it with continuous interlocking suture. This is a second type of closing the vagina. An alternative approach to minimize blood loss and avoid the spillage of vaginal content in the peritoneal cavity. Curved clamps are placed from the lateral to the medial at the level of the external os. The cervix is amputated with the scalpel or scissors. Using the size or absorbable suture, a running stitch is placed from the medial to the lateral on each side, overswing the clamp. The clamps are then removed and the sutures is pulled tight. This is another way of closing, and this is the third way of closing the vault. Leaving the cuff open to heal the secondarily, a running suture is used for hemostasis along with the cuff edges of the peritoneal defects superior to the cuff is sutured. There appears to be no difference in the post-operative febrile morbidity whether the vaginal cuff is closed or remains open. If you, this is also called a baseball stitch. If you close the vaginal angle, vaginal edges, you just keep approximate the anterior and posterior peritoneum which are opened while dissecting the broad ligament. So peritoneal cavity will separate, the vagina separate and abdominal cavity separate, and it will close with secondary intentions. So this is apical prolapse prevention. The association between hysterectomy and subsequent pelvic organ prolapse is controversial. Experts agree that the vaginal apex should be suspended at the time of hysterectomy to minimize the subsequent apical support loss. Common technique for vaginal apex suspension include intrafacial hysterectomy, as we've seen, and incorporate the uterosacral ligament into the vaginal cuff angle at the time of the closure. So it will slightly give support to the vault. After closing the vault, you must know the final examination and closure. The pelvis is thoroughly irrigated with warm saline or ringer lactate solution. Meticulous hemostasis at the pedicle is confirmed. The mop count, most important is the mop count and the instrument count is confirmed. The bladder and ureters are inspected. You must watch the post-operative urine, amount of urine, color of urine. It's very minor observation, but it is very important. When we dissect a difficult bladder, when we dissect the operated bladder, or there is likely chances of hematuria. But when we dissect it under vision, even if there is slightly hematuria because of the bladder vessel damage, there is no worry. If you dissected it under vision or dissected with the scissor or sharp dissection, if you do the blunt dissection, we are not aware about the whether it is a true bladder injury or whether it is only vascular leakage of the inside the bladder. So after that, you can start the peritoneal closure. Some people advise to do the pedicle closure. Some are not in favor to close the peritoneum, but I generally use take peritoneum along with the rectus muscle interrupted suture 2-3. So it will maintain the anatomy of the abdomen, and chances of adhesions, omental adhesions are very less. Now the facial closure. Facial closure should be reapproximation the wound edges without undue tensions or tissue ischemia. So here we can discuss about the interrupted suture or continuous interlocking suture. Generally, tissue is ischemia due to an uneven distribution of the tensions in interrupted suture, but continuous closure distribute tensions evenly along the entire length of the incision, allows better tissue perfusion and save the times. If the patient is fatty, if there is history of 2-3 cesarean sections or laparotomy for any other pelvic surgery, I generally use Prolene to prevent a recurrence of the recurrence and incisional hernia, because Vicryl gives in very weak strength to the rectus sheath, and chances of infection is more while using Vicryl for closure of the rectus sheath in fatty patients. Closing the rectus sheath, you can put a drain or depending upon the surgical situation, or you can close with the ethylene 2-0 interrupted or subcutaneous incision. If fat layer is 3, 4, 5 centimeter, it is always better to take a close the fat layer with interrupted sutures. You maybe use Vicryl, monocryl as per your choice. Okay, Shweta, sorry.
Yes, sir. Thank you so much, sir, for this wonderful and informative session.
Yes, I completed very fast all the surgical steps, and as far as the anatomy is concerned, if you have any questions or if you want to ask something or about incision, because I have not covered the basic surgical, basic theoretical part, how to take incision.
Very nice demonstration, Dr. Sujit.
Very nice, sir. Very
Everything stepwise, your steps are very clear, and bloodless surgery it was. Your hold in your surgical skill is very nice.
Now I would like to request Dr. Narendra Meena sir to take question and answer session. Dr. Narendra Meena sir.
Yes, Dr. Sweta. Thank you so much, Sujit sir.
Thank
you
you, sir.
have covered completely in your lecture. बेसिक चीजें जो है उसमें है, कुछ पीजी स्कॉलर्स भी इसमें जुड़े हुए हैं, तो मैं सोच रहा हूँ कि कुछ बेसिक जो थ्योरेटिकल क्वेश्चंस हैं
you can ask, sir. You can ask.
Yes sir. Sir, first question is what diagnostic tests are to be done before abdominal hysterectomy?
You want to mean before posting the case, what type of what are the tests we have to done?
Yes sir.
Okay, see, if you are operating any operative, basic tests are considered as hemogram, urine, sugar, thyroid, serological test. Okay. For hysterectomy, you can add a chest X-ray, ECG, and depending upon the pathology of the patient or pathology what you are dealing. If the patient is hypertensive, you must do STUDICO. Patient is diabetic, you must do HbA1c, fitness. If there is a history of bleeding, you can add PT-INR into. But you can simple do chest X-ray, ECG, LFT, urea, creat, serological test, BT, CT, and most important is endometrial and cervical biopsy.
Yes, sir.
Without doing biopsy, don't do the hysterectomy as per as for legal way of concern and as per the diagnosis is confirmed.
Yes, sir. Yes.
Okay, Dr. Sujit, just one question I want to ask you regarding if there is a broad ligamental fibroid or a lateral cervical wall fibroid. At that situations, we came across for a ureterolysis or ureteral dissections in that area. In such cases, how do you prefer to avoid the ureteric injury? And in the broad ligament fibroid, what precaution you take that there should not be a blood loss too much because it's highly vascular?
Okay. See, if you are dealing with a cervical fibroid or cervical pathology or broad ligament fibroid, it is always recommended to canalize the ureter. Ask your urologist to do the stent in the ureter. Okay. This is the most important.
You mean to say we have to stent it before proceeding to that procedure or later on?
No, before. If you are suspecting there is a compression on the ureter.
Yeah.
In this USG, you see the hydroureter, hydronephrosis. It is always better to put a stent preoperatively prior to surgery. First,
don't think that putting the stent prior to your surgery will make that ureter very straight, and it will means difficult to mobilize the ureter at that point when you are operating, particularly the broad ligament fibroid or cervical fibroid.
If you diagnose the
after doing a stent, and then the mobilization get restricted somehow. So what is your opinion about it?
Mobilization is restricted, but you can easily identify the ureter. If suppose there is small injury to the ureter happen, which is we are not recognizing at the time of the surgery, the stent will do its work. So you can even dissect now. You can start at the pelvic brim. If you are suspecting broad ligament fibroid, you don't touch the fibroid. You start dissection from the lateral pelvic wall. You start with the retroperitoneum. Identify the ureter. Just lateralize it minimally, and you can always remain close to the fibroid. Just keep under vision ureter.
Okay. You mean to say prior to that we should do ureterolysis first and then should proceed?
Absolutely. If you are dealing with lateral pelvic pathology or your pathology is on the lateral side, you always keep watch on the ureter, always keep under the ureter under your eye, and then only you can apply the clamp.
Yeah, and this condition mostly even we found in the endometriosis also, which is one condition while when we cannot perform the vaginal hysterectomy and we we prefer the abdominal hysterectomy. And in that case also, I think this step is very important to
if you are dealing with a lateral pathology, big pathology, adhesions, you start from the pelvic brim, or you start catch the infundopelvic ligament, open from that side, goes upward, don't go downward, goes upward towards the infundopelvic ligament along the lateral wall of the infundopelvic ligament. Identify the ureter at the origin, at the bifurcation of the common iliac artery, external internal. Identify the ureter there, and you start dissecting that pathology from there only.
Okay, and if you found a posterior adhesions, sigmoid or lower sigmoid region,
Cul-de-sac.
And then you proceed with delineating with the Ď-Lange fascia and pushing it back towards it. How should we get to know that the landmark towards the bowel dissection?
As I told, fat belongs to rectum and fat belongs to intestine. You remember that structure. Always dissect from the, if you open the retroperitoneum, broad ligament laterally,
okay,
you open the pelvic places and always dissect away from the fat. If you dissect the fat, it's very easily you enter into the sigmoid, enter into the rectum.
Sometimes in the adhesions, it becomes difficult.
It is difficult, but basics.
Normal anatomy, we can easily bluntly dissect it and take it put down in that normally. But during if you found the adhesions over there or the endometriosis over there, with that altered anatomy, it becomes difficult.
Is adherent. Fatty tissue is adherent. Generally, intestine, rectum is not adherent to the uterine in almost in every pathology. Omentum is adherent. You can remove omentum easily.
Yeah.
So what we look in the even if it is not an intestinal endometriosis, if intestine are not involved, then you can easily remove the omentum. It looks like an intestine is adherent to the pelvis, in the pelvis or in the cul-de-sac, but generally these are the omental adhesions are there.
Okay. And in a huge fibroid, do you prefer to take the uterine at its origin?
Yeah, in difficult fibroid, always take uterine at its origin.
Or in huge fibroid, I think
at least
vertical incision for maximum exposure.
What?
In a huge fibroid, means beyond 20 weeks or 22 weeks. Should we prefer a vertical, or can do go with along with the financial?
Depending upon the location of the fibroid. If it is on posterior wall, it is always better to take a vertical incision, generous incision. Okay. When we take a financial incision, fibroid or pathology on the posterior side, it's slightly difficult to take out that pathology easily. You get a minimal exposure.
Okay. How to?
It's a individual choice or individual way of doing surgery. But if you do the PVA examination, you will understand. Always do PVA. I generally prefer PVA examination under anesthesia, which will guide us. What type of incision we are taking, what type of pathology we are dealing, the ligament is how much stout or loose. So our mindset gets settled. When we do the PV examination under anesthesia, we come to know what type of case we are operating or how you are dealing with which type of tissue.
Okay. How you deal with the ventral fixed uterus while doing abdominal hysterectomy?
To the adhesions to the rectus.
Ventral fixed uterus means complete till the abdominal wall.
Generally, we just right now, Shona, after opening the rectus sheath,
You are not audible, Dr. Sujit. Hello.
लगता है मैडम इनका नेटवर्क प्रॉब्लम इशू है वो.
Hello,
Hello.
ma'am. Sir is not audible.
Yeah, sir is not audible. Shweta, just do one thing. Can you call him or a message him?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Sir is trying to join with us. Wait for a few seconds.
Hello. Hello.
Hello. Huh.
Sorry.
Yes, sir.
When you're operating now, you dissect. There are adhesions because of the surgery only. You dissect above the adhesions. You mobilize the rectus sheath and rectus muscle. Above that adhesions, you start open the abdomen from the virgin area.
Okay.
You start from the above, it will be easy to dissect. And always dissect at the expense of the uterus.
Okay. And in which situation we should decide if we have a cervical fibroid? So in that case, means how to decide whether it is a central fibroid or lateral fibroid? Vaginally jana chahiye ya abdominally prefer karna chahiye? In which situations we should consider that for abdominally? Because most of the times when it is on the lower side or in the central side, we prefer to do it with vaginally.
No, I am not getting you. If the fibroid is on the cervix.
Yeah.
On which side of cervix? If it is lateral to the cervix, there is a you do the first
preferable. Means for a cervical fibroid, which approach is good, abdominal or cervical, and how to decide it?
Okay, general to the per vaginal examination. If vaginal laxity is very good, patient is having previous normal delivery, laxity is good, very good, then you can judge under anesthesia properly whether the fibroid is at the cervix or at the broad ligament, because every time what the report says, it always not up to that mark or not correct.
Okay.
If you want to start the vaginal, you can put a laparoscope. What I do, I put a laparoscope in difficult cases, so you can easily identify which pathology you are dealing. So take that advantage and start it vaginally.
Okay.
But it's depend upon the individual skill. If you are confident to do vaginally, you can start. Anyway, if there is a problem, you can convert it into the abdominal hysterectomy.
Okay.
So if you feel it can be delivered vaginally, the fibroid is very good. You can after opening the cul-de-sac. I generally use to open cul-de-sac in a single bite. If you put the cervix, you pull the cervix upward and keep the LH on the vagina. So you get a particular plane where you can open directly cul-de-sac. See, if you're able to open the cul-de-sac, you can then put a finger inside the cavity and you can judge where is the fibroid. So what type of pathology you are dealing. Accordingly, you can start vaginally or you can move toward the abdominal surgery.
Okay.
But it's not a fixed protocol, depending upon the case, depending upon the location, depending upon the in which setup you are operating. Practically, if you are operating peripherally, then there is no point doing heroic surgery. So deciding all these factors decide whether do vaginally or abdominally.
Okay. Okay. Thank you. Shweta, please continue. Dr.
जी मैडम.
हाँ, Dr. Narendra sir, please.
सर इन 30 पेशेंट्स आपने बताया ना कि जो वाइक्रल से स्टिचिंग करते हैं, सुचरिंग करते हैं, तो उनके अंदर इन्फेक्शन के चांसेस का कारण क्या रहता है इन फैटी पेशेंट्स से?
The fatty patient, there is lot of serious discharges there. Lot of serious discharges there. Vicryl is very prone, as is biodegradable material. Now, vicryl is biodegradable material, and if there is a lot of serious discharge or serum formation, so it can easily give when vicryl degrade, it will easily give chances to grow the bacterial infections and pus formations. So generally, I use monofilament thread, proline, and put a drain there. So whatever the collection inside, it will come easily outside. Once the infection happens, there is nothing where you have to open the patient, you have to remove the threads. So it will hamper the patient's life. And there is a lot of chances to scar dehiscence, rectus sheath dehiscence, and that patient land up into the hernia in future life. So simple step, just forget about the vicryl, use the proline number 1 without interlocking stitching. See, there is no need to take interlocking suture at the rectus sheath. Anyhow, it is not going to bleed. If you take in proline and continuous suture, there are less chances of infection. There are less chances of tissue necrosis.
Sir, in a case of a psychovaginal fistula, the way the patient comes after later on after a few months, and which clinically first we should suspect that, and which test we should perform.
It's very easy to diagnose fistula. Patient is continuously leaking.
Yeah.
This is the patient don't have any control on that watery discharge. It gives only 2 diagnoses: is incontinence, or because of the surgery, it is a late fistula. If you put a simple thing, if you put the sterile gauze, sterile cotton or sterile dressing band in the vagina and just push methylene blue in the bladder, if the vaginal sponge or vaginal soak with the methylene blue, it's a fistula. After you can, this is a clinical test. After that, you can take the help of the radiological investigations. How much is fistula? So you can do cystoscopy. You can do X-rays also.
Is it mandatory to do a cystoscopy after your where you found a difficult abdominal hysterectomy?
No. If you dissect it under vision, you know what type of tissue you are cutting, which tissue you are cutting. So there is not mandatory you are doing cystoscopy for difficult hysterectomy.
Okay. Dr. Narendra?
जी मैडम. सर ये एनेस्थेटिक्स जो कॉम्प्लिकेशंस है उसके बारे में सर थोड़ा सा बताइए.
See, anesthetic complications mainly immediate जो होता है ना, जो आपको डर लगता है, that is a high spinal.
जी.
That is the most dangerous complication, and depending upon the patient's condition or patient's the status, cardiac status, respiratory status, anything can happen. But most problematic is total spinal. So one should be aware. Surgeon must be know while operating on the patient. When we take an incision, that surgeon must have feel that this is what type of anesthesia, relaxation is proper or not. If patient is slightly uneasy, you must know that it is a high, that spinal is going to be high. So you must know that anesthetic complications. Any complications are tackled by that anesthetic, but surgeon must aware about that complications. Yeah, you must prepare your OT with that situations. You must have endotracheal tube in your hands. You must have mepenterin in hand. You must have atropine, adrenaline nearby you. So these complications are treatable. And other complications, there are a number of other complications. But for surgery, if there is anesthesia is proper, sometimes motor anesthesia is very, sensory block is very good, but there is a less relaxations happen. So in that case, whether you are going to convert it into GA or just take a Cherny's incision, cut the muscle, and you can proceed your procedure. If the anesthetic is not competent or anesthetic is not willing to convert it into general anesthesia, sometimes level is very low. As far as surgery field is concerned, I am telling, if the anesthesia's level is low, relaxation is not up to the mark, pathology is big, And if your anesthetic don't want to convert it into GA, or there is no facility for GA properly, then you can take a Czerny's incision, you cut the rectus muscle so that that relaxation point was eliminated, and you can tackle your surgery.
Okay, how you deal with the DVT patients, sir? Deep venous thrombosis.
You can give a prophylactic, take a proper fitness and give a prophylactic 2-3 days of a DVT protocol, like Zen or all the drugs.
Okay. And preoperatively also you do something?
No, not every time. Some patients recommend the Clexane preoperatively, but not always recommended that drugs, because anesthetic people are aware about that. If you are giving anticoagulant, they don't use spinal anesthesia, so they want GA.
GA.
They generally ecosprin होगा चल जाता है, कोई problem नहीं है. Nowadays they are just avoiding clopidogrel.
Do you prefer a specific bowel preparation in normal hysterectomy also, or it is fine?
In normal hysterectomy, I don't use that much preparation. Simple 𝙁𝙁 gases will do that.
Okay.
In laparoscopic hysterectomy, generally we give 𝘋𝙬𝙗 with limca, peg leg. You have to done all that precautions.
I think abdominally इतना problem नहीं जाता है.
Abdominal इतना problem नहीं आता है. 𝙁𝙁 sufficient हो जाता है उसमें, because you are going to pack that instrument. But I found many people are doing abdominal hysterectomy with the use of Doyne's retractor, and they are very much struggling at the cervical level. So I don't know why they are using. In simple cases, in thin patients, Doyne's retractor will work. But for deep retractor, for intestinal retractor, for deep bladder retractor, one must use Doyne's retractor for exclusively for hysterectomies.
But even that, the pressure of that retractor also gives means so much pressure if we are putting over there. Now there are chances for the nerve injuries.
You Doyne's retractor upward, don't push it backward. Ask your assistant to push the upward. So you are lifting the anterior abdominal wall along with intestine and mob. You are not pushing it backward. If you are pushing it backward, it will compress the but 1 and 2 mobs cannot compress that much. But still ask your assistant to lift the intestine, not the push backward.
Okay. Dr. Narendra?
Ji, Suji sir,
yes,
what are the special circumstances where we have to remove the ovaries?
Special circumstances means if the patients have a history of genitourinary malignancy in family, they have a history of CA breast in family. In such circumstances, we remove the ovaries. Otherwise, ovaries is very useful organ. I generally avoid to take out the ovaries. If there is a torsion, if there is a tubo-ovarian abscess or ovarian abscess, ovaries torsion, and after removing the torsion, still we found the ovary is not properly working, or there is a lot of pus collection in the ovary in tumors. In that circumstances, we remove the ovary.
Okay. Next, how to prevent wall prolapse after hysterectomy?
As I told you in last slide, it's the part of slightly controversial, but you can give a support of uterosacral McIntosh ligament posteriorly to the vault while suturing the vault. That much you can do. But you are doing an intrafacial hysterectomy, so there is a very less chances of vault prolapse.
Do you prefer to ligate the uterine double ligation and all?
Generally, I don't prefer to ligate doubly. We are ligating under vision securely one tie, so there is no point to ligate it separately. Otherwise, you keep ligating 2 times, 3 times. Unnecessary.
And if you found a big tumors, in that case, vasculature of IP ligament, and with that tumors, how will you manage this situation?
I'm not getting.
For a tumors, means we preferably you do first means this we separate.
What happens in large tumors? I generally when you open the abdomen, I just use 10 cc syringe, puncture the mass, aspirate it.
And what about the spillage then?
No,
if you are not.
If it is not endometriotic, then it's okay, no? If it's endometriotic, it's not dermoid cyst, then you can test, no? If you do puncturing with 10 needle, it is not, spillage will not happen. Decompression will happen only. If it is simple cyst, then there is
How
no.
do you come to know without any histopathological report?
No, you can puncture the cyst, aspirate the fluid. No?
Okay.
Aspirate. No? If you want to remove it totally, if you don't want to puncture the cyst, if you want as in removal.
Sometimes we think it's a simple cyst, but somehow if under कोई histopath में उसमें find out होता है, so I think means removing the whole TO mass is better than.
Depending on the pathology, if it's a simple cyst, you can puncture it and remove it. So it will minimize your incision, minimize your complications. You can give a proper wash. If you are suspecting endometriosis, if you are suspecting dermoid, some chances of chemical peritonitis, it's always better to go lateralization. Find out the ureter. Then the method is same. Find out the ureter, dissect it laterally, and you can take it out from there.
Yeah. Dr. Narendra?
जी, आफ्टर हिस्टेक्टोमी सर जो इंड्यूस मेनोपॉज एक वही कॉम्प्लिकेशन ही है ये, तो उसका क्या करें, उसका क्या मैनेजमेंट करें?
As per as I say, don't remove the ovaries, because ovaries are functioning till the end of life. Even it is atropic and there is no pathology, then don't induce patient into the surgical menopause. And if you want to treat surgical menopause, there will be different things, how to treat HRT and all that things. But don't put patient unnecessary in surgical menopause. It is a very sharp surgical menopause. So generally, even after menopause, if there is no specific history, we find a ovarian tissue. It may be shrink or it may be atropic. I generally prefer not to remove ovaries. But tubes, in every hysterectomy, one must remove the fallopian tubes. Always hysterectomy is accompanied by the removal of the both fallopian tubes, as it prevent, theoretically, as it is prevent to the, it may be the cause of the CA ovary. So always remove bilateral tubes at the time of hysterectomy, whatever may be the indications of hysterectomy. It is fibroid, abnormal uterine bleeding. If you are taking uterus out, take the both tubes. Also, it will prevent CS ovary. Second thing, you are removing the one infectious source. If you are putting tube inside the cavity, it will give infections, salpingitis, collection here, hydrosalpinx, in number of tubal pathologies there. So there is no point to putting tubes inside the cavity at the time of hysterectomy.
Okay, so sir. One more thing. Even obstetric hysterectomy is also should come under that. So आप उसके बारे में थोड़ा सा बताइए.
See, depending upon the reason, this is placenta previa.
I mean to say the procedure only, means not indications.
No.
Means what special precaution you take while doing obstetric hysterectomy?
While obstetric hysterectomy, I have performed 2 obstetric hysterectomy till date.
Okay.
So always remains, try to ligate clamp properly before applying. Think 2 times before applying the clamps, because there are very less chances.
That is the main thing. Because if you want to suppress the blood loss, clamping is very important.
Think 2 times before applying the clamp, because there are in a normal hysterectomy you can put the clamp 2 times, 3 times, there is no problem. But in obstetric hysterectomy, there is if you are putting clamp and removing it, it will give major blood loss.
Yes.
Right, it will bleed terrifically. So go consciously, step by step. Apply the first clamp on the specimens, and then depending upon the ovarian ligament size, if you are not able to conserve the ovary, in that condition, you can apply clamp laterally. Take out the infundibulopelvic ligament and directly dissect the peritoneum, broad ligament. And
there is a vascular congestion in that area.
There is a lot of vascular congestion, but don't look at the venous congestion, it will stop. First, take out the fundus out. Then apply the clamp at the incision, below the incision of the uterine incision, transverse financial incision. You can put their clamp and hold it for 5 minutes, 4 minutes. All the bleeding will stop. But main problem is that if you are not applying clamp under vision, or if you want to remove that clamp, there is a big risk. So if you apply the clamp, don't remove it. Ligate it properly, because secure, and then you can proceed further.
सर एक चैट बॉक्स से भी है क्वेरी, ऑब्स्टेटिक हिस्टेक्टोमी व्हिच विल बी प्रिफर्ड, सबटोटल और टोटल? ये
सबटोटल
डॉक्टर जागृति पाटिल का क्वेरी है।
See, if the bleeding is from the fundus, you have to do subtotal hysterectomy. Don't remove the cervix as the patient is very young. And there is a lot of functions of cervix. It will keep vagina moist and all the things. If the pathology in this, that's why I say, if you are dealing with the atony, you have to remove the fundus, because atony from the fundus, atony from is not from the lower segment. If you are dealing with the cervical pathology, if you are dealing with the placenta previa, bleeding is from the cervix or bleeding from the vaginal artery, there is tear from the lower segment. If you are doing obstetric hysterectomy for the tear in the cervix, then it's obviously total hysterectomy. If there is atony, you can simply go for the subtotal hysterectomy. Don't touch the cervix. If it is pathology is below the incision of the uterine incision, pathology is that cervix, pathology at the lower segment, then there is no point to doing subtotal hysterectomy.
We would like to see your obstetric hysterectomy also, sir, in next section.
Why you want to teach? It's a nightmare of doing a hysterectomy.
No, I mean to say, if the chances, if you come across for obstetric hysterectomy, uska video leke rakhiye hamare liye.
But there are very less chances of doing obstetric hysterectomy in which a cameraman must be available. We cannot wait for that cameraman. If this happen, then we'll do definitely.
Yes,
definitely we will shoot that.
Do it for us.
Now, see, this is the I am especially thanks to you and all NIMA-OBGYN colleagues. See, because I am operating from last 15 years. But I generally don't shoot I shoot the surgeries and delete it after the storage is full. But because of the NIMA-OBGYN, because of all the NIMA members, this is a very great platform that where we are going to present our cases. There are some people which they want to learn from our side. This is a good platform to share the knowledge. That is the best part of the NIMA-OBGYN. There are a lot of senior people are there. They are guiding us. There are a lot of junior people are there. They are doing much better work. So it's a good platform to upgrade the skill of everyone. That is the success of that NIMA-OBGYN.
Thank you.
And this is my first lecture. By the way, this is my first lecture. I'm not familiar to give lectures and all that. So mostly
you should do that actually. You're a good demonstrator.
I can demonstrate
now you make a habit to make the videos and putting it in the group. बाकी लोगों को भी सीखने का मौका दीजिए सर आपसे.
It's happened because of that our Hirlekar sir, 𝘼𝘃 sir, all NIMA central team and all you people, because of you all the team, NIMA team of Maharashtra and India, this platform is there, which will definitely help each other.
This is, I think, the support from all our states and all over India colleagues.
No,
because of their support, I think we can do it.
Absolutely, without the help of our seniors, because these are the people I know. These are the people.
These are the pillars.
When I'm a student, I saw Hirlekar sir, other Detrankar sir, all that sir. They are performing open surgeries. They start open surgeries around 10, 15, 20 years back. That's why we are now performing laparoscopic surgeries. So this is a journey. So it must go on.
Because of them, we can see the icons.
Absolutely. Because of our all senior teachers and all senior doctors in OBGYN, because of them only, they make a small platform. They start practicing OBGYN. That's why we are now talking in front of all the peoples.
Yes.
They are not doing the platform now. It's very difficult to us to practice nowadays in Pune.
Yes.
now no one is asking, anesthetic not asking, you are who is doing. I used to do a lot of seizures, high risk cases at allopathic surgeons. Allopathic surgeons calls now. This is big achievement.
That's a nice thing that you are performing in most of the referral centers. You go there. So I think it's a good chance for all of you to learn from him. And you should put your videos, means I think I'm appealing to all the surgeons, whatever you are doing in your practice, let the people to know about it and let the people to know the skills of that particular surgery. So it will be beneficiary for all. Means I know it's a time taking, but थोड़ा सा टाइम निकाल के अगर अपन ये सारी चीजें करते हैं,
it's good beginning. It's good beginning actually. It's good beginning for all of us. Those who want to
आपके थोड़े से टाइम से ना वो बाकी लोगों के लिए वो बहुत ही मायने रखते हैं, आपके थोड़े से टाइम. तो आई थिंक कि ये एक सब सर्जन्स ने वो थोड़ा सा ध्यान में रखना चाहिए कि अपनी मतलब स्पेंडिंग इतना सा टाइम 2 मिनट्स अगर कोई भी अपने इस सेशन के लिए ऐसे थोड़ा सा भी देते हैं अपने सर्जरी के इसमें से, तो आई थिंक कि वो आप जो स्टूडेंट्स है या फिर जो अभी स्टार्टअप किया हुआ है सबके लिए वो बहुत अच्छा रहता है. Any questions, Dr. Narendra?
मैडम ये इनके चैट बॉक्स में है, इनको क्या माइक इनका अनम्यूट करने के लिए कहें, जैसे इनका 2 है.
हाँ बिल्कुल बिल्कुल सर.
Okay, one of the patient is detected with the hemorrhagic cyst solitary.
Yes sir, yes sir.
You must know
Please. Gone through Wadham system. Dr. Narendra, please read the questions.
Okay मैम, ठीक है. One of my ये है मैम, इनका डॉक्टर राहुल कुमार है, उनका है one of my patient is detected with hemorrhagic cyst on solitary ovary post hysterectomy. What is your advice?
Sir, we must know the size of the hemorrhagic cyst. If it is a 3, 4, 5 centimeter below we can conserve it. It will go on its own. If it is bigger in size, you can put a laparoscope and you can take it out.
Okay.
Next question.
एक है डॉक्टर जागृति पाटिल का है. I have seen the patient who have gone through hysterectomy. Then after that she has unilateral pedal edema. USG color Doppler reported were normal, but after 24 days she went through MI and passed out. What will be probable cause?
No, I am not getting you. What is happened? Unilateral pedal edema?
Yes sir. USG color Doppler report
Thrombosis.
Thrombosis. Okay. Yes, USG color Doppler reported were normal, but after 24 days of hysterectomy, she went through MI.
It is a maybe minor amount of thrombosis or congestion, which is not detected by the sonography, so it will disappear in the 24 hours.
Okay.
If it is a vaginal hysterectomy, because of that position, the things are very common: perineal nerve injury, popliteal nerve injury.
Okay.
Hello.
If it is abdominal hysterectomy, most commonly is a venous congestion and minor amount of that thrombosis.
हेलो.
हाँ बोलिए मैम.
हाँ सर मैं बोल सकती हूँ, आवाज आ रही है?
आ रही है मैडम.
You are audible ना, please.
Yeah.
सर एक्चुअली वो वर्धम सिस्टेक्टोमी थी, क्योंकि एडेनोकार्सिनोमा था, पेशेंट को डिटेक्ट हुआ. तो वर्धम हिस्टेक्टोमी होने के बाद यूनिलैटरल एडिमा था. तो पहले तो ऐसा लग रहा था कि लिम्फ नोड हम डिसेक्ट करते हैं तो उसकी वजह से अगर स्टैग्नेशन हुआ होगा लिम्फ का, तो इसलिए हो सकता है. लेकिन फिर भी प्रोफाइलैक्टिकली कलर डॉपलर किया, कुछ मिस नहीं होना चाहिए इसलिए. कलर डॉपलर के रिपोर्ट्स एब्सोल्युटली नॉर्मल थे, कहाँ पे भी थ्रोम्बस वगैरह नहीं दिखा। लेकिन 24 डेज के बाद पेशेंट को सडनली चेस्ट पेन एंड मतलब MI के सिम्टम्स दिखे और पेशेंट सडनली पास हो।
It's a thromboembolic effect, ma'am. Whether you are detect or not detect, you cannot detect everything on the sonography or the color Doppler.
Okay.
Although it's a lateral dissection, lot of venous dissection, so that is venous congestion, which may be a small, very little amount of thromboembolism is there.
Okay. सर फिर इसमें हम प्रोफाइलैक्टिकली ऐसा नहीं होना चाहिए, इसलिए क्या-क्या प्रिकॉशंस लेनी जरूरी है?
You can do a early, see, before surgery you can give a Clexane to 2 to 3 days. You can start Clexane, and after surgery you can mobilize the patient, proper adequate physiotherapy. You can do only these 2-3 measures only.
Okay, sir. Thank you so much.
Early ambulation in such cases is very important.
Early ambulation, physiotherapy immediately.
Yeah, stockings and all these things.
And every hysterectomy, to start to patient, remove the catheter as early as possible. Also, patient can mobilize easily. If you put the catheter for 2 days, 3 days, some people are keeping catheter for 3 days for no reason. If there is a bladder injury, you can take catheter for 10 days, 15 days, it's okay. But if it's not injured, you can remove it in 24 hours. No? And start any surgical patient will start mobilize very early.
In such patients, preoperative preparation is very important. When you are dealing with Vardhams or postmenopausal woman, preoperative their evaluation is very important. 2D echo and physician fitness. These things are very.
If you are doing Vardhams, you must do all the physical hematological investigation. You are suspecting DVT, you are suspecting embolism. So you must know chest X-ray properly, 2D echo properly. You check the cardiac output, any other pathology, cardiac conditions. Generally do this such type of cases under institute backup.
Yeah.
In small, see, they every time my physicians write patient fit for surgery. But always remember the patient is fit for surgery in which setup. That is very important. You have to, being a surgeon, being the owner of the hospital, you must decide the patient whether it's fit in your setup. The patient which is fit in my setup, unfit in my setup, it may be fit in a bigger institute.
Okay.
So accordingly, just to have, you must have clinical that place. As per the case, you must decide whether which test you are done. If you need if you know you are needing a ICU backup, then it's always better to shift the patient in ICU setup, and then you can do it there.
So actually, the patient was my relative, and she is operated at the well-known institute by the well-known surgeon.
These are not surgeon's fault. This is not surgeon's fault.
Yes,
it's because of the extension of the pelvis or heavy dissection at the lymph node. Patient can react in any way.
Okay, yes, sir.
These things can happen. These are the known things.
I'm not blaming the surgeon, but I just want to know what precautions when I will do the procedure in future. Then what?
Yeah, definitely. I got your point.
Yes. Whether to give the prophylactic heparin or ecosprin to patients or not.
Clexane. Nowadays, people are preferring Clexane injections. It is better for prevention of venous thrombosis and all that.
Thank you so much.
Any other questions from audience? Dr. Shweta?
लगभग कंप्लीट हो गया मैडम इधर से।
Shweta, are there any questions again?
No, ma'am, there is no question.
Okay,
from
then
chat box. And now I would like to request Dr. Narendra Meena sir for vote of thanks.
On the behalf of NIMA-OBGY Society Central and NIMA-OBGY Society Maharashtra, I would like to express my gratitude to NIMA Central, Dr. Vinayak sir, Dr. Ashutosh Kulkarni sir, and U.S. Pandey sir for their remarkable support to form NIMA-OBGY body. I extend my gratitude to our NIMA-OBGY Central President, Dr. Kamini Dhiman Madam, Secretary Dr. Priyanka Nakade Madam, and Treasurer Dr. Vishnu sir for supporting and guiding us to conduct today's seminar. I would like to thank and extend my gratitude to our eminent speaker, Dr. Sujit Shinde sir, who took time from their busy schedule and delivered a very knowledgeable and wonderful session. I would further like to extend my gratitude to our NIMA-OBGY Maharashtra President Dr. Subhash Helkar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay sir for all their support to conduct today's webinar. I would also like to thank Dr. Daga sir, Dr. Archana ma'am for all the help and technical support required for the smooth and uninterrupted functioning of the webinar. Last but not least, I would like to thank from the bottom of my heart to all the delegates for their participation and presence. Without them, this webinar would not have been possible and succeed. Now, with the due permission of all the dignitaries, I am conducting today's webinars. Thank you all for attending, and we hope you have learned and gained great knowledge from today's webinar. Looking forward to see you soon in our next webinar. Thank you. Thanks to all.
Thank you, Dr. Sujit. Thank you so much for your valuable time for today's webinar. It was a wonderful webinar demonstrating each and every step on abdominal hysterectomy. We learned a lot from you. Thank you so much.
Thank you so much, sir.
Dr. Sujit?
Sir, शायद left कर गए.
No. I think he has lost the connection. Dr. Shweta? Dr.
Yes,
Shweta?
Yes, ma'am.
Just want get the confirmation, Dr. Sujit.
Yes, ma'am. Ma'am, I think sir is not able to join with us.
Okay, no problem. So we will conclude the session now.
Yes.
Thank you.